Good evening, everybody. We're delighted you're all here and interested in outpatient palliative care. It's an honor, in this group especially, to give this talk. Would those of you who have had someone close to you with a chronic serious illness like heart failure, chronic lung disease, cancer, diabetes, or dementia, please raise their hand? Then you know how complicated, heart-wrenching, and expensive the management of their disease, symptoms, and quality of life can be. How many of you think you may be called upon in the future to help care for someone with a serious illness, or even yourself? Because when one person in the family becomes ill, the whole family experiences the illness. Now, thanks to advances in modern medicine, Americans are living longer, fuller lives, even with chronic serious illness. Long periods of physical dependency, however, are still common, and such patients on average see 13 physicians a year. And today's somewhat fragmented healthcare system has not kept pace with the management of serious illness, and it makes it difficult to effectively treat these patients, just when these numbers and needs are growing exponentially. We've all experienced what it feels like to be rushed through a doctor's visit, a visit where there was not time to talk deeply and broadly and to address multiple real concerns. And sadly, in some cases where this occurs, care can suffer from miscommunication between physicians. Patients can be confused about multiple prescriptions and treatments, and redundant testing or even unnecessary treatments might occur. In years past, our family doctor used to manage most of this, and now may still have time to manage a single important clinical problem in a visit, like COPD, but is really too busy to coordinate the complex mix of clinical, emotional, social, and spiritual care to meet the patient's needs and goals, to optimize useful care, and to avoid unnecessary care and the treatment burden that may go along with it. So doctors have existed in every society and culture to guide and accompany patients through serious illness. And as these patients now are our sickest and most vulnerable patients, both the patient and the physician need help. We need a team, a whole team, a palliative care team, who all together act like a concierge at a fine hotel, who guide you on your journey to the fine restaurants, tours, hikes, and special sites that you might not see otherwise, making your visit full, enjoyable, and memorable. We need a concierge palliative care team to manage symptoms like pain, fatigue, and depression. And physical symptoms are not even the patient's biggest concern often. Fear of disability, of dying, of suffering, of losing your job, of not being able to take care of your own family. And of course, financial concerns are more commonly what patients lose sleep over. Consider these statistics. Today, about 90 million Americans, or 25% of the American population, live with serious illness, and understandably account for about 66% or 2/3 of U.S. healthcare costs. This number of patients is expected to more than double in the next 25 years, possibly becoming 40 to 50% of the population in 2045. Of these 90 million patients, it's thought that at least 6 million of these should have palliative care. This is 2% of our population. This proportion, if we look at it in Whatcom County, would mean about 4,500 patients who would benefit from this. So locally, for example, PeaceHealth clinics care for 1,500 diabetic patients, 2,000 patients at our cancer center, and fully 27,000 patients at our cardiovascular center, with 4,000 cardiology consults newly coming every year. Early referral to outpatient palliative care could relieve some of the burden on these busy specialties and clinics. So a more intelligent paradigm is clearly needed. Palliative care is that paradigm. So what is it? What is palliative care, and how does it work for the individual patient? Well, say a patient diagnosed with a serious illness like stage 4 cancer is ideally referred early in the diagnosis, even during the first visit, or at any stage in the illness for that matter, to a palliative care team of physicians, nurses, social workers, chaplains, and volunteers who have the time and skilled communication with the patient and the family and everyone else on the team to do four main things. One, manage symptoms like pain, fatigue, depression, and difficulty sleeping. Two, to customize care to the individual patient's needs, wishes, and goals, and their physical, emotional, social, and spiritual needs, and honor their wishes at each visit, and allow the patient through education and family to understand their treatment, the kind of issues they might meet, and put those wishes into advanced healthcare directives. 3, the team coordinates treatments, medications, and appointments so the patient doesn't have to manage their own complex care plan alone. And 4, the team meets on a weekly basis to discuss every patient's integrated palliative care. And all this, as you can imagine, is extremely fulfilling to our palliative care team and the patient. We would like to clarify that palliative care is not the same as hospice. Hospice is reserved for terminally ill patients in the last 6 months of life, when treatment can no longer cure, but certain treatments can certainly comfort. Palliative care, on the other hand, begins ideally at diagnosis of a serious illness. It can be started at any stage during the illness. It's appropriate at any age and can be incorporated alongside life-prolonging and curative treatments. It can be provided regardless of whether the diagnosis is terminal or non-terminal, and is normally continued right through hospice later at the end of life. So palliative care doesn't require hospice, but is almost always given as part of hospice. This is already, fortunately, a national, international, and local movement. In Washington State, for example, 65% of hospitals have palliative care programs. Nationally, 77% of hospitals our size have these programs, and at hospitals larger than St. Joe's, fully 93% of hospitals have programs. So palliative care programs are now the rule in United States hospitals, not the exception. On an international level, in the year 2000, palliative care was included in the United Nations International Covenant on Economic, Social, and Cultural Rights. In 2013, essential medicines for palliative care were included in the World Health Organization's Essential Medicines list. And in 2014, the World Health Assembly passed a resolution appealing to member countries to include palliative care into their mainstream healthcare system. Locally, you'll be glad to hear that inpatient and outpatient care have already begun. We have been working hard on this, a lot of people in this room. 7 years ago in 2012, due to the great generosity and venture philanthropy of the River Styx Foundation and Jim Swift, we brought inpatient palliative care to our hospital. This was kickstarted by these foundation funds for the first 3 years, and the hospital took over what became a largely self-sustaining process in 2015, 3 years later. Since 2012, the inpatient palliative care program has provided 4,187 consultations. So you can see the need for palliative care in the hospital and afterwards is great. The outpatient program, you'll be glad to hear, has started last September 2018. We currently have 74 patients enrolled working with the team, and we hope to have 100 or so by this coming September. And then by 2024, in 5 years, hope to be serving about 250 patients annually. The goals of inpatient and outpatient palliative care, I should mention, are the same. The only difference is the location. Patients need not be hospitalized to receive palliative care. They can receive it conveniently in their own homes, in residential facilities, or working even in an office setting, like Meg does. So visionary hospitals understand that palliative care is a triple win, equally benefiting the patient, the physician, and the healthcare system. And a Regions Foundation survey found that fully 96% of physicians support palliative care. It is actually the fastest growing surgical or medical specialty in America today. And every specialty, really every adult in America would benefit by learning more about it, because it is only when our culture understands it and its value that we will truly be able to adopt it universally and have it take its place as a robust insurance benefit. In essence, I would say palliative care is the best care possible. designed to create the space and time to treat the vast complexity of medical issues. Palliative care is the best care at what may be the worst time in a patient's life because it empowers the patient to live well and be treated with respect and compassion. In essence, this is the care we all want. So why is the foundation doing this for 5 years? 4 main reasons. Number one, there are, as I mentioned, thousands of patients in Whatcom County right now who would benefit from this care. Two, most palliative care services like social work, nursing, volunteer coordination are not covered by insurance. So we need to cover this gap now until private insurance, Medicare, and Medicaid can evolve a better palliative care benefit. And three, the hospital has asked the foundation for help in this endeavor, and our board has become passionate about it. And four, this fundraising, as all fundraising, will free up funds for other critical projects, which there are always many, as Dale will tell you. For right now, example, the hospital is expanding medical services in Linden by building a 20,000 square foot facility for medical and specialty care, building a new women's health center, and going to start construction soon on a hybrid operating room for complex vascular cases. The point is, we can do some of these great projects without philanthropy, but with philanthropy, we can likely do them all, and they're all important. So the foundation is committed to this, to provide the first 5 years of kickstart funds for operational startup expenses for outpatient palliative care in Whatcom County, to create a full, comprehensive, integrated program and build program sustainability for the hospital to take over in 5 years. So you probably wonder, what is that sustainability program? What's our plan? And here's the crux of it. Palliative care is a value proposition for the medical center. It improves, many studies show it improves patient and family satisfaction. It reduces hospital admissions, 30-day hospital readmissions, crisis calls to 911, emergency department visits. It reduces ICU utilization and reduces hospital length of stay while increasing the completion rates for advanced care directives. Once a patient is admitted, it's known to save 9 to 25% of inpatient costs through a combination of decreased length of stay and decreased costs per day. Outpatient palliative care programs have been shown to save as much as $12,000 per enrollee and naturally allow for more timely and appropriate identification of patients for hospice and longer lengths of hospice stay, which are needed. Our projection is for 80 additional hospice referrals to Whatcom Hospice every year and a 10-day increase in the length of hospice stay, both of which would help pay for the outpatient program when the hospital takes over in 5 years. Because palliative care focuses on the highest need and highest cost patients, it's a great strategy for population health management to reduce cost and improve outcomes, both parts of our mission. They say if palliative care could fully penetrate all the hospitals in the United States, the savings annually would be $6 billion. So as you can tell, we're energized about the success of palliative care so far in our community. We know it's the right thing to do. We would like you to join us in our commitment to make outpatient palliative care the best care possible for our most vulnerable, sickest patients to enable them to continue to live well.
How do patients know about the care that's provided or that's available?
Right. So I think it's a slow cultural adoption process that will probably take quite a while. Physicians need to educate their patients. Patients need to educate themselves, you know. I think probably more community-wide forums could probably be helpful too.
We are also providing a palliative care academy for a lot of community providers that we've offered to primary care and specialists, and we've had a lot of participation in that to continue that education so that folks know what it is, how to have those discussions, and when to refer. We're telling more and more people every day and opening those referrals. We've built that into our electronic medical record so that our providers know how to refer and make that easier. But that's a slow process that we've been doing to continue to do that education in our community.
Where do we go from tonight? We talked about community education. Continue this conversation. I think that's one thing that we've all discussed on here, is making sure that we use the word palliative care, make sure we're telling our family and our friends and our neighbors. And then in the following weeks, we'll be reaching out to you and asking if this is a project that you would like to support. And ask those questions. If there's board members or palliative care committee members, we're here to answer questions. So thank you.